CataractCoach.com, fixing a closed pupil from uveitis. Now, obviously, there must be some flow of aqueous, but that vision is just light perception. I mean, look at that. So starting off here with a couple of pairs in TCs, and the patient had some sort of uveitic episode in the past, caused a lot of sneak gaze, pupil so tiny. Now, what are you going to do in this case here? Well, I think the first thing I do is that tripod's not going to do a whole lot. It's not going to stain any capsule. You're not even touching the capsule. You can't see the capsule. So I wouldn't have done that. Here's the viscoelastic going in. Yeah, I'm just going to have to slowly but surely dissect that pupil, kind of open it up. Yeah, be careful there. I'd use two hands. Use a forceps in each hand and get that expanded a little bit more. There you go. Now you're starting to look at a good-looking little pupil there. And then just check if there's a membrane. Yeah, do a little bit of stretching. Be careful, though. With the stretching, you can actually rip the iris. Oh, that's a big rip. That's a lot of ripping. So you want to be very careful there. You may want to, next time, try to think of doing microsphincterotomies. That's a big rip right there. So once you've expanded this now, you basically have no sphincter muscle left, no tone left. You've got some irregular rips there. I'd put in iris hooks. In a case like this, I like the flexibility of iris hooks. Now, okay, starting off here, and I'm making a main incision. There we go. I think iris hooks here will be a lot easier for you. Much better than pupil. Okay, you can use a pupil ring. It's not my choice. Looks like a B hex ring, putting that inside the eye here. And this is like a ring that is going to expand the pupil. You just hook it on the margin. There we go. You're using these micro forceps. And you can get all these sides in. It's kind of hexagonal in shape, so B hex. And now you've got a reasonable pupil. Center that up a little bit. And that's great access. There it is. There we go, getting the rexes done. Now, the rest of the cataract part's going to be pretty straightforward. Do the cataract surgery. Luckily, it's not too dense of a cataract either. You got a reasonable red reflex there. And another pair on the other side. Okay, and an iris hook. All right, belt and suspender. Sometimes you need that to get a little bit better view there. I don't know if you really got the edge of that B hex, but okay. So now, gentle on the hydro dissection. Be careful. You see iris is already kind of prolapsing. There's going to be very little iris tone. Going in with the phaco probe, obviously the video sped up, don't worry about that. Going inside here, and looks like a chop. Making short work of the nucleus, that's great. Now I'm interested, what are you going to do with the pupil here at the end, the iris? Now you'll get the lens in the bag, do you just leave it? But again, we did have some large rips of the iris. And so if you leave it alone and just do it, your patient's going to have this now large midriatic pupil, like 5 millimeters, and non-reactive, and like, yeah, do you leave that? I'd probably do a pupiloplasty. Once you get the eye in the capsular bag, aim for a pupiloplasty. And now you can do a regular pupiloplasty. You don't have any pinhole because this patient obviously doesn't have any issues in the cornea. Cornea looks pretty good. So I'd aim to do about a 3.5, 4 millimeter pupiloplasty at the end of the case here. And let's see, cleaning up the cortex very nice with the bimanual approach. That looks just fantastic. That is beautiful. And then put some viscoelastic, get the lens in, monofocal lens here. Obviously, measure the axial length with the A-scan. Here comes the lens going in the eye. And then when in doubt, choose a little bit of myopia. Myopia is a gift. You know how much I like being a low myope. Get those haptics unattached from each other. Get that in the capsular bag. And that looks great. Looks like it's behind the rectus, so the eyeball's in the bag completely. Going behind the optic here. Very talented surgeon. You're doing a beautiful job. And now let's see what else we're going to do here. Yeah, the big question is, what are you going to do with the pupil? Because you can see how the edges of the iris look a little bit ratty, a little rough there. So we caught, at the beginning, the stretch caused some, tears there, basically. So a better option sometimes is to do just with the micro scissors, do like tiny microsphincterotomies. So see, take this hook out, and now let's take out the pupil expansion ring, the B hex ring. You can just pull that out of the eye. There it is. And let's pull that ring out, and let's see what we're left with. So slowly unhook this ring. Be careful with this iris because, again, it doesn't have much tone. Iris being like that forever, the muscles of the iris have just atrophied completely. So now let's get that there, get it out. And it doesn't look too bad. But with the eye still full of viscoelastic, I'd do a little pupiloplasty there, especially where the surgeon sitting, looks like the surgeon sitting superior. I think that superior section right there needs to just one suture would help. See how the edges are ratty right there? So, it's the bottom of your view, which is the patient's superior. I think that could definitely use the suture. Now, look at the iris prolapsing through the paras. So, that just shows you how floppy this is. There's no tone of this iris at all. You're not going to have any normal pupil reaction here. So, I'd put a couple sutures in, do pupiloplasty. Look at it prolapsing out the incisions. Look at the para and the main incision. Definitely, I'd put pupiloplasty, and I would also suture up that main incision, maybe even some of the paras. Last thing I want is iris trapped in there. So here at the end, okay, putting an air bubble in. Are we going to call it quits here? All right, maybe washing that out. I'd do something. Oh, look at the iris. It's still prolapsing out. Look at that. See, I tell you, you'll want to do a pupiloplasty here. You really, really want to do a pupiloplasty because it'll help prevent that iris from prolapsing out of the incision. You definitely want to suture the main incision and even those paras. You just don't want any grief here in the post-op period. Let's see what we're going to do next. I mean, I'm watching the video for the first time with you. We're learning together. Okay, suturing the main incision I like, but I still want to do that pupiloplasty a little bit. Because otherwise, you're going to end up with this very large pupil that's going to be, it looks like it's a little asymmetric. It's not going to have much reaction, won't have any reaction at all. Patient may have some issues coming with the mydriasis now. You have the tiny pinhole meiosis. Now you're going to get the opposite, chronic mydriasis here. So there's a nice looking suture. Good job there. Oop, oop, came undone. Try that again. 1, 2, 3, grab. There it is. And then nice and tight. Good. The other one and tight up. And then that's it. Cut it up. And again, I'm still thinking I want to have the pupiloplasty done. Now, you can always come back at a second sitting and then do the pupiloplasty. You don't have to do it now. Here's a little triamcinolone that's going to help. Obviously, it's going to obscure your view. You put a lot more than I put in. I put very, very little. If I put triamcinolone in the AC, you're looking at a half milligram from me. This is a lot more than that. And, of course, the view then is kind of, there we go. We'll swirl that around a little bit with BSS. Wash some of it out of there. I guess you're going to leave it be. Put an air bubble in, call it a day, right? Let's see what happens post-op day 1. You've got a picture coming up soon. Yeah, again, I still think you should do pupiloplasty because otherwise patient may not be thrilled. Or patient will be obviously better than before. But here's post-op day 1. Yep, see that? I think the patient would definitely benefit from pupiloplasty. Suture there superiorly, one there nasally, and it'll be a nice outcome. Thanks for watching. Submit your video, CataractCoach.com. Also, retinarounds.com. Check it out.